Hello, everyone. Good evening, good morning, good afternoon. We are just waiting for more of our friends to join, and then we will start. Yes, I see a lot of us joining, and let's give it 5 minutes. Already 3 minutes past, 2 minutes more, and then we'll start. Hello. Okay, so we have waited for 5 minutes and we have many of our friends here. So, good evening and good evening from Nepal, Kathmandu, because I'm here. And good morning, good afternoon, wherever you are. Hope you're having a good time. And as we end towards closing this year, we need to talk about or reflect on how we have done on self care. That's why today's discussion, unlocking provider potential, how self-care strengthens health system under pressure. We have been a lot of pressure in 2025. We all know that. And I think this is a good reflection to begin with. So, with this, I welcome you all. We have a series of amazing speakers, and I'm very happy, proud to welcome all the our speakers, our friends, our service providers, our community leaders who have joined us today to reflect on this important area when we are looking at from government's perspective, service providers, and also from research perspective. So with this, I will be introducing our speakers as they come and start. I am Dr. Harjot Khosa, working at International Planned Parenthood Federation South Asia office and as a regional external relations director, and I'm an advocate for self-care. So very happy to moderate today's discussion. We will have recording of this session available to all of you. So don't worry if you miss anything amazing, you'll get the recording. Please do share your amazing question, target it on a speaker or all, whichever you like. And also, if you can briefly self-introduce yourself in the chat with your name, organization, that will be fantastic. So, with this, I'm very happy to start today's discussion. And our first amazing speaker to start off the conversation is Dr. Alex Argo, sorry, my pronunciation. So, Dr. Alex is leading Population Service International's health system work. A health economist by training, he has over 30 years of experience in developing more efficient health systems and tackling health inequalities in low and middle income countries worldwide. With this, I request Dr. Alex to please come and tell us that how should we go ahead and what is it that we should build on, our learnings and our knowledge from your past 30 decades. Dr. Alex, over to you, please.
Thank you for the introduction, Dr. Ajot. Good morning, good afternoon, good evening, everyone. I'm joining you from Tokyo, which, by the way, was the epicenter of UHC last week with the high-level forum. First of all, I'd like to thank the organizers for inviting me to join this panel. Over the next few minutes, by the way, if you can change to my presentation, that would be great. Yes, thank you. So over the next few minutes, I'll be speaking about the economic case for self-care in SRHR in low and middle-income countries. Next slide, please. Before diving in, I want to acknowledge the state of the evidence. Overall, the economic case for self-care in low and middle-income countries is promising, but it's still very fragmented. Much of the formal economic evaluation comes from high-income countries, while LMIC evidence is not only much thinner, but it's also much more focused on very specific interventions rather than looking at self-care more generally. Also, I think it's important to keep in mind that in many LMICs, self-care is not always just a convenience. It's often the only realistic access point, especially when the workforce is overstretched. Yet, available tools for measuring its economic value are not really designed to reflect that reality. So as I go through the different slides, I'll be using a very simple color code to indicate where the evidence is strong, where it's moderate, and where important knowledge gaps still remain. Next slide, please. Let me start with the challenge. Put very simply, we face increasing SRHR needs across low and middle income countries, while heading towards a global shortage of 10 to 11 million health workers. And many systems already struggle with overstretched providers. So self-care offers a very practical opportunity. We have strong evidence that it reduces the burden on facilities, that it saves users time and money, and that it expands reach to people who might not otherwise access SRHR services. Next slide, please. So in a way, self-care changes how the health system works from an economic perspective. More care can be safely managed outside health facilities, which lowers the volume of simple repetitive visits. This also simplifies care pathways, reducing unnecessary steps and easing bottlenecks, which in turn reduces households' out-of-pocket spending on health. And importantly, it improves the efficiency of the existing workforce. And I'll get back to that in a second. Next slide, please. As I mentioned in the beginning, most of the available evidence relates to very specific interventions. And for at least some of the SRHR interventions, the evidence is already pretty strong. And that is definitely the case for HIV self-testing. And to a large extent, this is thanks to the important research component that was built into the PSI-led STAR initiative. It has shown, for example, that introducing HIV self-testing in outpatient departments increased testing among men and youth from about 45% to more than 70% while using less staff time than standard provider-initiated testing. So this is one of the clearest examples we have of self-care both expanding reach and reducing costs. Contraceptive self-injection reduces non-medical costs and produces significant health gains. In Senegal, for example, it was estimated that for every 100,000 users, self-injection could avert around 1,400 unintended pregnancies and over $200 per year. HPV self-sampling is generally considered cost-effective in low and middle-income countries, especially where screening coverage is low. It boosts uptake, it reduces women's travel time, and when coupled with effective follow-up treatment, it outperforms against more cost-effective from a cost-effectiveness perspective against traditional methods like visual inspection with acetic acid. So these are just a few concrete examples. Next slide, please. The HIV self-testing example I just gave from the STAR initiative is a perfect illustration of what many refer to as the workforce dividend. More generally, what that means is that by reducing routine, low-complexity visits, self-care directly frees up provider time. And that time can then be redirected towards tasks that only skilled providers can perform, at least for now. This may then also generate other benefits, shorter waiting times, better quality, reduced burnouts, but these remain understudied. So there's definitely a need for more research here. I believe we'll hear also more about this from my co-panelist, Karen Aura. A quick note here that in principle, it should be possible to model health workforce optimization under self-care scenarios. The different building blocks that we need for such modeling exist, but I was unable to find any good example of a model that combines them. In other words, a single dynamic economic model that brings together self-care uptake, health outcomes, reallocation of provider time, workforce productivity gains, and the resulting cost savings. So here's another need for further research. If one could build such a model, I think it would be a very powerful tool to inform policy decisions. Next slide, please. We already kind of touched upon this in some of the examples given earlier, but I think it's important to make it very explicit. Self-care also functions as a preventive investment. Research that was conducted under the STAR initiative, for example, was able to demonstrate that preventing late HIV diagnosis averts significantly higher lifetime treatment costs, which is why several HIV self-testing models are cost-saving in long-term projections. In the same way, preventing unsafe abortions, unintended pregnancies, or late-stage cervical cancer can avoid substantial downstream costs. So while this preventive effect is clear across several specific interventions, we still need better return on investment models that quantify the long-term system savings of self-care more broadly. Next slide, please. If we really want to realize its economic and workforce potential, self-care must be fully built into health systems rather than being delivered as pilots or through donor-funded projects. And this means including self-care in benefits packages and incorporating it into broader domestic financing arrangements. It also means ensuring that we don't shift the costs onto users, which remains a risk in many contexts. And in fact, there was a recent BMJ article that shared that high-quality evidence on the details of how to finance self-care in ways that don't dump the costs onto the end user remains very sparse. So here's yet another area for further research. And we need to strengthen the system components that make self-care work at scale, like procurement systems, digital support platforms, and community-based distribution. And Uganda is one of the countries that is quickly moving in that direction, and we'll get a chance to hear about it from my co-panelist, Dr. Achola. Next slide, please. So to conclude, self-care should be seen as a way to redesign service delivery so that countries can use scarce workforce capacity more strategically. We have strong evidence for cost savings and for reducing routine facility visits. We have promising, though still emerging, evidence on larger prevention dividends. And we need stronger long-term economic models to capture the full return on investment. But overall, self-care remains one of the clear strategies to complement overstretched health workforces and strengthen SRHR systems in low and middle income countries. Next slide, please. So thank you all for your attention, and back to you, Dr. Arjia.
Thank you so much. Thank you so much, Dr. Alex. And talking about workforce dividend, I think we all are striving to make our health systems resilient. And we want that health is put in hands of communities. And today is, we're just 2 days away from UHC Day. And even this year campaign is stressing on that, we need to make, the unaffordable health cost. We are sick of it. Yes, we are sick of it. We want that every community member, every woman, every young person who wants a health service should get it. And when our health systems are resilient, we will put it in their hand. So thank you so much for this amazing discussion. And with this, we are very, very excited to have Dr. Rosaline Ekola with us. She's a public health specialist currently serving as a SRHR and self-care family planning technical specialist at Uganda Ministry of Health. She brings around 2 decades of experience of designing, managing, and implementing SRHR-J programs at UNFPA. She's currently a member of Self-Care Expert Group in Uganda, a multi-stakeholder group established by Ministry of Health in 2020 to adapt WHO guidelines to the local context, resulting in the development of national self-care guidelines and the piloting of intervention such as self-injectable contraceptives and HIV testing. Very, very important areas, and we need to learn and push our governments, nudge our governments to make this happen in all our countries. So with this, Dr. Rosaline, I request you to please come, and over to you from here. Thank you.
Thank you so much, our good moderator. Good afternoon, everyone, wherever you are. I'm happy to be part of the panel to share with you the experience that of self-care in Uganda. Next. Is anyone moving the slides for me? Next. So Uganda has embarked on the journey to institutionalize self-care in the healthcare system. And my presentation will definitely talk about the policy perspective, how we've integrated self-care and perspective and the achievements therein. Next slide. So as a way of beginning the presentation and sharing with everyone in this call, I would like to say that Uganda's experience that we have worked over time has demonstrated that when we institutionalize self-care, it's very possible. And while doing this, we need a more sectoral approach. We also learned that integrating self-care in the healthcare system does not only involve piecemeals, but we need to do this from national policy frameworks up to the community engagement if it must be sustainable. And as a country, we have established self-care expert group led by the Director General himself, and this has given us a very good headway. And because of this, we have also adapted the WHO guidelines for health and well-being and also developed the self-care investment case. Next slide. I want to say that from our national, next slide, from our national coordination mechanism, we've ensured that different ministries, different development partners, the private sector, the civil society, the youth, next slide, please, have all been part of this agenda, and we have moved as a way of ensuring that self-care is well implemented in the country. I also want to say that when we piloted self-care in the 2 districts, you've moved very fast. Maybe go back a step. When we piloted self-care in the 2 districts, it showed that capacity building for health workers and village health teams can see and quality of self-care delivery. And we also realized that with collaboration across programs, as I already mentioned, that coordination is key. At Ministry of Health, looking at the different departments, non-communicable diseases, the AIDS control program, the pharmacy, adolescent health, and the sexual reproductive health, has helped us to strengthen efficiency and commodity security. And because of the need for us to look at and align to the global standards, we commemorate annual self-care awareness month that has helped us to be able to actually continue popularizing self-care. Next slide, please. So I must say that the institutionalization of self-care process in the country has been, it's not a parallel system, but we've looked at self-care as complementary to supporting the healthcare system in strengthening health workforce, but also supply chain management. And in doing this, it has helped us to leverage some internet networks to reach the last mile. We've also realized that the self-care practice that we have adopted in the country has helped us to increase awareness, self-care testing, and management, which is working towards realizing the universal health coverage. Next slide. If you look at this, next slide. If you look at the next, where I have the pictures, yes. In this picture, we have members of parliament. And this is one of the ways how we enhanced our policy enabling environment, knowing very well that members of parliament are very key. And the reason why we brought them on board is basically to ensure conducive environment, but also resource allocation, domestic resource allocation, using the investment case that we developed. And this, we are proud that has given us a very big headway. As self-care policy enabling environment, we've also worked with professional and regulatory bodies to support the different laws and quality standards that help us then to harness innovation and ensuring that consumers are protected. As Minister of Health, we are currently, and we've done some work with Minister of Education to review the curriculum using the WHO competency framework. And this is to help us ensure that the training of health workers align to the global standards. Next slide. In as far as our policy environment is concerned, still, we are doing all this because we want to realize access towards universal health coverage. And we can only do this when we integrate self-care into the existing health system, when we strengthen primary health care management, work with other stakeholders to ensure that we build synergies and promote health. And when we do this, then we shall realize accelerated progress towards universal health coverage. How have we integrated, next slide. How have we integrated self-care into the health system? It's an area that really, as in Uganda, we are sharing with the rest of the world to appreciate the journey that we've made and how we've managed to actually advance self-care in our country. Like I said earlier on, integration in the different departments has helped us to ensure that all the departments are implementing components of the self-care priority interventions. From our guideline, the self-care national guideline, we have about 8 different intervention areas. And those different intervention areas somehow rely on different departments. For example, the SRH, where we have family planning, self-injection, it falls under reproductive and child health department. We have the SCP program, where the HIV self-testing is managed. We have the community health, where community distribution of self-care commodities, supporting women to inject themselves at community level through the community health care workers taking place. Pharmacy, where quantification and forecast is done. We need the pharmacy department. So the integration in all these Ministry of Health departments has helped us to advance the agenda. Then digitization. We have Self-Care Uganda application, which is helping us to continue popularizing self-care interventions. The application takes a woman through the process of how she can inject herself, how she can do her HIV testing for both men and women, and everyone is entitled. Health promotion. We also developed the self-injection scale-up plan and rolled out the tools that is helping us to capture data that we need. And therefore integrating into the existing primary health care and the Ramna frameworks has helped us to improve efficiency and ensure continuity of care beyond the health facility. Next slide. So what are the lessons that we've learned globally? We've learned that success depends on embedded health. And as a country, like I've already mentioned, we have worked diligently to ensure different primary health care interventions are well integrated. Ensuring equitable access to commodities, like I mentioned, working with pharmacy. We have the self-injection, the HIV self-testing kits, blood pressure monitors. All these are crucial because they must be forecasted and quantified for us to have it in the country. And we've learned this, that globally it's very important to ensure commodity security. Then maintaining data visibility, monitoring and learning frameworks. Globally, we know that we have to report to the self-care stabilizers group using the dashboard. But how do we do this if we don't have a monitoring framework in place? National guidelines contextualization. When WHO developed the global guidance, we quickly jumped on and contextualized our. So we learned globally that we needed to align with global standards. And then the competency framework that I have just mentioned. The next slide, please. So what are the achievements that we have gained as a country? The task sharing with community health workers and health community and VHTs has helped us to increase access to self-care and self-injection in Uganda. The achievement that we have also registered is integrating NPA self-care, self-injection into the essential medicines list and the Uganda clinical guidelines, which is an achievement that we've embarked on the process and we have managed to do it. As a country, we have approved the self-care injection policy. That means every woman or girl who needs self-injection with the DMPA is covered because the policy is there. Then integration of self-injection indicators in the HMIS, which I've just mentioned, it's helping us to actually capture data. And that's a very big achievement. Then approval of administration of DMPA in pharmacies and drug shops to scale further access to DMPA at community level. And of course, integrating this in the family planning 2030 priorities, and of course, in the FPCIP and the investment case. Next slide. Our achievements further reveal that in community health strategy, which has been developed as a country, we have self-care included in it. And this has made it easy that the community health department are in position to actually implement self-care interventions using the strategy that is in place. Then interventions that are included in the strategic plan is also talking about how Ministry of Health is moving towards ensuring that self-care interventions and practices are well practiced by country, by the population. And then the enhanced policy environment for self-care generally, that we have the Director General, we have the members of Parliament, we have the President in his manifesto telling the country that he wants to see health, and well-being on top of his agenda. That means self-care practices that are beyond sexual reproductive health, going into health and well-being, as we talked about, non-communicable diseases, HIV self-testing are very, very important. And he has this as one of the issues in his manifesto, which to me is a big achievement and giving us the courage to continue advancing self-care agenda in Uganda. And of course, commodities, which I've just talked. Next slide. So this slide is basically trying to show the different areas as a country. We have achieved a lot. We have hosted so many countries that I can't list here, coming to learn from us. So that means there's something unique we've done that is inspiring other countries to come and learn from us. And our doors are still open. So we thank God that this is achievement that we have registered and many countries are learning from us. Training health workers and having the WHO competency framework formalized in the country is a very big achievement. Establishing multi-sectoral committee involving the different ministries to rally behind self-care priority intervention is very important. And of course, increased awareness where we have the religious leaders. Next slide. We have the cultural leaders. We have the media. If you see in this slide, it's basically showing us the cultural leaders rallying around self-care, and in between them, there is a lady in a dress. That's the minister, bringing all cultural institutions in the country to sign and adopt self-care. Next slide, please. Then we have the religious leaders. Religion is one of the key pillars in our country because we say for God and my country. So bringing them on board, you can see amidst them, we have the permanent secretary, showing you the level of political will and support, having religious leaders to sign that they are going to use their platforms to continue advancing self-care in Uganda. Next slide. However, with all the good achievements that we've had, we still have challenges. And one of the big challenges is the digital inclusion, where our tools offer opportunities for people to learn more. But even with that, we still have inability to access smartphones and literacy information that can help them to use the digital platform that I've mentioned. In commodity security, we still have pockets of stockouts. We have supply chain bottlenecks, much as we have health stocks at national level, but at facility level, there are still pockets of stockouts that we need to address. Limited information, as I already mentioned, particularly to the rural community, and then the cultural norms and related SRH issues regarding the young people is still a challenge. And of course, poor decision-making power that our women still have, and unaffordability of salary commodities that Alex already mentioned, especially in the private sector for those who go at that level. In conclusion, lastly, next slide, I would like to say that self-care institutionalization is achievable through policy commitment, multi-sectoral partnerships, and community ownership. And so doing this, then self-care will be our pathway to universal health coverage that will help us to empower individuals, reduce inequalities, and strengthen resilient health system that will then respond to both routine and emergency needs of the people of Uganda. I really want to thank you so much for listening, and we are honored that we have participated in this webinar. Thank you so much, and over to you, moderator.
Thank you so much, Dr. Rosaline. Always an inspiration to see how government of Uganda and you people, advocates, are leading the change that we all need. And we all are trying to learn from you. So thank you so much. People, if you have questions, please send them in the chat. And if you need anything on more details from Dr. Rosaline, please do let us know. With this, we quickly move ahead to our third speaker. We are very happy to have Karen Ora with us. Karen is a reproductive health specialist with Ministry of Health, Division of Reproductive, Maternal and Child Health. She has extensive technical expertise in developing policies, guidelines, protocols, standards, and training materials in reproductive health. As a team lead, Karen has spearheaded development of key documents, including self-care policy guidelines, post-abortion care guidelines, family planning policy guidelines, and many more. So with this, Karen, we are very excited to listen from you. Over to you from here.
Thank you very much, Dr. Kosa, for allowing me to present at this particular time. And hi to everyone. Welcome to this presentation. Karen Aura is my name from Kenya. So I'll embark direct to the presentation. Kindly put my presentation up. Thank you very much. So the outline of my presentation, I think you forgot the title. Yes. I'm going to discuss about rethinking professional roles and trust in terms of self-care. How can self-care be able to reduce burnout and enhance quality of care in terms of the healthcare providers who are providing this service and being able to cascade it to the clients? Next slide, please. So my outline is about how do we rethink the professional roles as healthcare providers? How do you be able to reduce burnout in terms of implementing self-care? What are the dynamics and enhancing quality of care when we are cascading self-care to the clients? What are the empathy and the core competencies in terms of healthcare, in terms of self-care? What are the benefits for the providers and the community in terms of self-care? And why does health system support self-care? Especially, I'll give an example in Kenya, then I'll conclude. Next slide, please. So, as we all know, as healthcare providers, there's a lot of demand in terms of self-provision at the health facilities, and this and the services are provided in our country, especially in Kenya, are person-centered health services, and we have a lot of strategies in terms of making sure that self-care implementation is efficient and the clients can be able to trust and the outcome becomes better. We also help to empower the individuals who are the clients to manage their own health without the provider involvement besides giving health education. And in Kenya, we align self-care with UHC priorities because we are practicing primary health care. Next slide, please. So how do we rethink professional roles? We are moving from the traditional model to whereby the provider is the gatekeeper because they are cascading these particular services to the healthcare to the client, and then we're also involving the needs at the health system so that we can be able to shift and empower the client and being in partnership with the client. We also want to implement the intervention that have been provided so that we provide access to the client and then be able to improve the continuity of care. Why self-care matters to the providers? Because they reduce the workload, because remember, we are now task shifting, task sharing at this particular level with the clients. We're also decreasing the stress because now the healthcare providers are only remaining with technical services at the facility because they have cascaded the easier ones to the client who can be able to do them by themselves at home. We also support the provider because now they focus more on complex cases at the health facility. Next. So how do we reduce burnout when we are practicing self-care? We are moving from controlling access to making sure that we are enabling safe environment for the clients by giving them information so that they can make informed decision. We're also strengthening patient confidence and sharing responsibility, whereby the patients, most of the time, they are taught on how to be able to perform these tasks by themselves and then come back when they feel that they need more care. We're also having been able to have less time and pressure so that we can be able to improve both the mental status of the clients and the healthcare providers so that emotionally they are well. Then we also reduce routine workload, e.g. refills, follow-up visits is reduced. Also improve job satisfaction through shared responsibilities because you have already given health education to the client, cascaded that particular skill to the client, and the client can be able to perform it by themselves. Then the private experience is less compassion, fatigue. The healthcare providers now remain with more complex cases to handle in the facilities, and then the workload is reduced. Next. So how do we do trust dynamics and enhancing quality of care? We're able to provide skepticism about patient readiness. The patient is ready because you have given them education, taught them the skill that they can be able to do it at home by themselves. Concerned on safety, misuse, and loss of control, this one is demystified because you give them health education. Need for mutual trust between provider and clients, because you have faith in your client. You have taught them a skill to be able to do this particular. For example, I'll give an example of you are dispensing contraceptives. You have given them, do not skip. You have given them. When you skip, what do you do? When do you come back to the facility for provision of more or for more health education? Then self-care builds confidence through user involvement and ownership. More time for quality interaction with high-need clients, because remember, before you allow a client to do this by themselves, you have given them information. Better follow-up and continue when clients can self-manage. When the client can manage themselves, they become more vigilant and they take care of themselves. Strengthen trust and share decision making, because we have already shifted the decisions and they can be able to make the informed decision. Support patient client care models. Next. Empathy as a core competency. You are able to understand fears on both sides: provider workload, safety, liability, clients. There's a lot of stigma in some of the products, but now they are demystified. Privacy and confidentiality is also provided when cascading this particular service to the client. Empathy reduces resistance and enhances quality of care, because now you are empathetic and being able to teach a client on how to be able to take care of themselves at home and only come to the facility. You're also enhancing quality of care, supports respectful, right-based service delivery, because you are doing this with respect. Next slide. Enablers for the transition. There's a lot of trainings in terms of self-care. So this one is competency-based approach. You do a lot of counseling, a lot of coaching, and a lot of supervision for the client so that they can be able to take up this particular service. Then the digital tools, decision supports apps are also given to the client so that they can be able to do self-directed learning. Self-care learning platforms are also provided for the clients so that they can read more information for themselves. Telehealth follow-up is also key. Team-based models. We use task sharing and task shifting. For example, in Kenya, we have healthcare providers at the facility level, and we have community health providers who are providing services at the community level. So they visit household every month for them to be able to follow up this particular task. Community health workers and pharmacists are frontline support, because pharmacists are also being trained to do counseling in their pharmacies and offer services. Next slide. So what are the practical examples? Some of the practical examples are already been given by Alex in his presentation. Pharmacy-led HIV self-testing. This one is already happening in Kenya, even at the community level. Community refill models. Community health providers are being taught to become community-based distributors. That one increases access. There's a lot of privacy, and early diagnosis done so that interventions is done early. There's also DMPA-SC, which reduces clinic burden and empowers client. In this case, in Kenya, a client is taught at the facility, and then the continuity is done at the community. Then they can be able to self-inject. They are given 1 year contraception so that they only come to the clinic when they actually need to see a provider. There's also better adherence and improved outcomes because they have been health educated up to the community level. There's digital self-care tools that are online that a client can be able to access and read and have more information. Self-management for NCDs, patients can be able to monitor themselves in terms of blood pressure, taking diabetes tools in Kenya at the community level. This one is done at the community level. Next slide. So what are the benefits to the providers and the community in terms of self-care? Reduction of workload and congestion, more time for complex cases, improved client satisfaction and trust, lower emotional and professional burnout, increase access, privacy, and autonomy, reduces travel costs and clinic congestions in terms of client, earlier detection, and timely care seeking, so the burden is reduced. Next slide. So why should we be able to advocate for health system support in terms of self-care? We need to align to the WHO self-care framework. We need to develop guidelines and policies. We need to train in terms of counseling and supportive supervision. We need to fit in budgets so that you can be able to allocate budgets for supply chain for commodities. When they come to the facilities as clients, they can be able to be provided these tools and even commodities. We should also be able to develop digital tools and community engagement, and we cannot be able to do this if the system is not strengthened, and we need budget allocation in terms of the ministry doing that. And in Kenya, this one is done. Next slide, please. So in conclusion, we need to have self-care implementation at all levels. And we are saying self-care is not replacing professional practice, because remember, self-care, the complex cases and the technical ones are the ones that are ending up in the facility, and then the workload is reduced, and then the patient is taken care of better. Provide remain essential as educators, supporters, and quality stewards. Embracing self-care strengthen trust, autonomy, and quality of care. Self-care is a critical strategy for reducing provider burnout. It frees resources, improves client outcome, and enhances overall quality of care. Investing in self-care strengthens Kenya journey towards UHC, and in Kenya currently we are practicing primary health care. Thank you.
Thank you so much. Thank you so much, Karen. And yes, I echo with you. No UHC without self-care. We need it. So, and definitely we need to understand the dynamics. And I really love that you spoke about empathy, because with the changing times and the current political climate, our communities, our women, we need confidentiality, we need safety. So definitely this is an amazing way to think. And with this, we move on. I'm very, very happy to invite our next speaker, Maureen. Maureen is a business lead of Via Health East Africa, a social business that is transforming healthcare of women and girls in Africa, Asia, Latin America by ensuring equitable access to affordable, high quality information, products, and services. She has over 15 years of experience leading health tech social enterprises and digital innovations across East Africa. In her current role, Maureen delivers sustainable growth, market expansion, and inclusive health access in Kenya and Uganda. So, with this, Karen, I welcome you, and over to you from here.
Hi, and thank you so much. And yes, I am just apologies. I know we are running out of time, and I'll be quite precise and fast in my presentation. And as my presentation loads, as I'm talking about the health system efficiency through person-centered digital care, it would be good to note that we are not just a digital platform, but we are a data-driven women's health business that basically expands access, choice, and continuity of care to women and girls from menstruation to menopause. And our key goal is to build scalable, sustainable market solutions, not only in Africa, but also across the globe. Okay, next slide, please. And how does VIA do this? So yes, we are a person-centered digital platform, and our key focus is on sexual and reproductive health. We have a good geographical footprint, not only in East Africa, but across the globe, with our key touch points around and working with pharmacies, clinics, labs, licensed providers, and also products distributors, basically to ensure that, because we have product owned, but also we work with different partners in ensuring that the quality of products are able to be distributed to places where people do not have access to. Right, next slide. Okay, how does VIA improve provider and system efficiency? And one key efficiency problem that we do understand is, one, the high volumes and complicated routine visits. Basically, if you take, for example, Kenya and Uganda, and you need to visit a clinic or a hospital, one, it takes a lot of time on the waiting time, and also a bit of more complications from when to see a doctor to when actually getting a diagnosis done to actually even getting a product. And also the congestion, mostly in public county facilities. And how do we ensure efficiency within this specific mechanism and flow. So FAST is the digital first line of engagement, which is done mostly on our social media, touch of a button. So it's Instagram, Facebook, TikTok, but most of that is mostly on WhatsApp, where people are able to DM us and we are able to try this to be able to understand what exactly they need, and we refer them to the right either service, product, or support that they need. And how is this impactful is one, unnecessary facility visits, because when they come to us, they're able to know, do I need to go to a clinic or directly to a lab? Or do I actually know with the specific diagnostic, do I just get a prescription and I'm able to get the product that I need through our e-commerce, because we have the telemedicine facilities, right? And that way then providers are able to spend more time on the complex and urgent care, and there's a lower cost touch points absorbed also for the specific need of the customer. Next. Okay, so this is just highlighting the person-centered outcomes as efficiency drivers. And what are those key things and that we track? Basically is that when the broad conversations we have around the family planning options, the self-efficacy, and also ensuring that people are able to make informed decisions to be able to get the right service and product they need. And also with them being informed, they're able to be confident in their choices and know what exactly they need for them, not just because their friend used something, a specific product, or went for a specific service. They should do that as well. We're enabling that they're getting the right information to be able to make confident, right choices for themselves. Right? Next slide. And a lot of them will be like, how does this work from the market to demand routing, and what is the benefit on that? So when you look at the demand creation and the system belief, one, the kind of information is already qualified, and most of it we work with specialists to be able to get the right information to push to our customers. And most of the demand is routed to, once we've already spoken to the customer and giving them the right information. So this demand is routed, one, to the local pharmacies, especially now the specific campaign, our information you're pushing around the self-inject and creating the knowledge that self-inject is available in pharmacies. So we are able to route people to the nearest pharmacy to them. We have a geolocate on our website that we are able to route the nearest pharmacy depending on where the person is. We are able also to route them to the clinics if they need follow-up physical touch points with a specialist. And on the labs part, we are able to also offer the at-home sample collection or also refer you to the nearest lab, and the telemedicine enablement where they're able to get or speak to a specialist wherever they are with their phone, either on chat or video. And how does this benefit the system? At the end of the day, it's a smoother customer journey, and you're able to get the information at the right time and when you need, and the right information and service and product that you need, right? And also, we're not working alone on this. We are working with different providers from the different respective either pharmacies, hospital, clinics, labs, and the tele providers are from the specific partners, hospitals, and clinics that we work with. Next one. So what actually makes this work, and this will speak more to the kind of the digital innovation we have, which is the first one that I've spoken about, which is the digital triage with referral threshold. So if you come to us, you're able to understand, okay, what kind of contraception you need, or what kind of specialist you need to speak to, whether it's for family planning, whether it's for menstrual health, we're able to refer you to the right service provider to speak about that. Hence the provider linkages either to clinic locators, pharmacies, or for teleconsultation, we're able to refer you to the different partners that we're working with. And for on the supply chain integration with the branded and reliable product availability, like I mentioned, we do own our own products, which is the menstrual product, contraception, and also we work with other partners to be able to push specific products as well. And also with the right focus of counseling and person-centered support and referral, we are able to ensure that the people get to the right service, the right provider, and the right product that they need. Next. And then this is the last slide, and what policymakers can do to ensure that there's the smooth integration with that is just ensuring that the digital triad and the self-care platform as a similar tool with the seamless connection, and also integrating them into primary care and the task shifting from strategies to ensuring this is full on execution. And also at the end of the day is with the different people we're working with to ensure to scale this. We are not only just finding the pilots and then leaving them and need to not sustainable projects, but also funding all the way to implementation. And what is the supposed evaluation of this? Of course, is ensuring there's the facility load reduction and people are able to get services at the right time without long queues, because at the end of the day, a lot of triage is being done online and not at the facility level. One, and the other key thing that would be ensuring there's time saving on the workforce, and then cost per need metrics is reduced. Thank you.
Thank you so much, Maureen. And we need to really take up these lessons. And somebody mentioned about menopause and congratulated you in the chat, and also the role of pharmacies and how do we build on it. So very, very insightful discussions, and closing here on these notes. These are high notes. So with this, I request all our panelists to please jump in. We have some questions coming in your way. Some people are very excited. Those who are more excited, please put your questions in the chat, and we'll be very, very happy to request our panelists and speakers to respond to you on this. With this, moving on to the next round, as the questions start pouring, I request Dr. Roslyn that we have a little question building on your presentation. Uganda launched its national guidelines on self-care interventions for health and well-being in 2024. What were the most important regulatory or policy enablers that helped move the guideline from concept to implementation? Some advice on that, Dr. Roslyn?
Yes, thank you so much. I'm happy that that question has come up, but what I want to say is that the enablers that helped us to move from concept to implementation, one is that top leadership by the Minister of Health that helped us to continue moving with the support of the leaders, which in particularly in this case is Dr. Olaro Shells, the Director General, who is the ambassador of self-injection in the country. Also working with the regulatory authority, which is the National Drug Authority. They have a robust system that has helped us to register and actually allowing self-care commodities. For example, the DMPA sub-QSI was received very fast in the country, registered, and that really enhanced our process that there is acceptability by the country. But also the establishment of the self-care technical office with a dedicated expert who is the technical advisor, SRH, and self-care, that is Rosalind Achola. It really helped us to move the process very fast, because when you are dedicated to move an agenda, you move it easily and liaise with all the different regulatory and professional bodies on time. The professional bodies we have in the country for nurses, for doctors, were brought on board and have supported this very fast. When you hear the commissioner nursing speak, you really see that self-care has taken root in Uganda. And then the evidence that we had where we piloted self-care in the 2 districts, the data, the evidence that we got from that helped us to really justify that it is possible. And it made our work very easy to go through the process of developing the self-care guideline to the level that we are now implementing as a country. Thank you so much, and over to you.
Oh, no, thank you so much. Thank you so much, Dr. Roslin. And Dr. Orano has been a brand ambassador globally, and I've been requesting him to plan a travel or trip to South Asia. We need that kind of leadership. So thank you so much, and keep building on it. Next year, we'll champion it more. So with this, Maureen, we have little question for you, jumping on to you right away. So, which user insights or design choices have been most influential in ensuring that self care tools remain safe, intuitive, and tightly connected to provider follow up?
That's a good question. So several key insights have shaped how we design our ecosystem. One would be we've gotten to understand that women want privacy, but not in isolation, right? So self-care features both offers like autonomy and also reassurance with experts. But when you think about it, when women are going through something and then they understand other women are actually going through it, they understand actually I'm not alone in this. So that's why we've been able to create women groups to be able for, and we've managed to demarcate that, like from younger women, from let's say 17 to 25, then 25 to 35, and 35 and above, because all these women are going through different things. But also the kind of conversations and insights they're learning each other, we found that to be very important, and they're able to open up around this. That is one. Number two, users respond to clinically validated, like if you're able to simplify it as basically simplified, like you're talking to you're not using the scientific jargon, but you're able to disseminate information as simple and as personalized as possible. We've seen the uptake and understanding of this has been able to improve, like the more efficiency and the more referrals that we're having to the different partners that we have. The next one is always know that context matters. And the geolocation has really helped us to direct users to basically the nearby pharmacies that are trained and stocked, and ensure like continuity from digital there, and also to traditional brick and mortar that we have across the country. And also the other key thing is understanding that trust. If they trust your product, it will drive conversations and it will drive uptake of the kind of service and product you're referring them to. Yes, those are the key insights we've been getting on that.
Thank you so much, Maureen. Thank you so much for this insight. And we have more questions coming your way. We will be getting back to you soon. With this, I move to Dr. Alex. Dr. Alex, you shared this amazing insight. However, we are really intrigued. We really want to know that across the countries where PSI supports self care integration, which policy or financing adjustments have proven most important for making these approaches stick at a scale? Over to you, Doctor.
Yeah, thank you for the question. So, which policies, financing adjustments? I think the example that we heard tonight or today from Uganda is really a great one, where we see that the adoption of self-care guidelines and then really the effort to implement those guidelines have really been able to move the whole self-care agenda. I think on the financing adjustments, there's still a lot of work that needs to be done in general. I'm not speaking specifically to Uganda, but I think there's still, and I believe I touched briefly upon it during in my presentation. I think there's still a lot of a big knowledge gap as to how best to incorporate self-care into existing health financing mechanisms, so that we don't really put the cost or push the cost onto the user. So I don't think we have. There are definitely avenues that need to be explored. How to build it into purchasing arrangements. How to build it into benefit packages, as mentioned earlier. But there is not much evidence yet there to show whether and how it works best. So I think there's still a big field to explore there.
No, no, thank you so much, Dr. Alex. Yes, Uganda and others are championing, and these little interventions guide us every day. So thank you so much for that. And with this, Karen, yes, Karen, thank you so much for sharing. Like you build on some very soft areas which we really need to understand. However, my little question to you is that trust is essential for safe self-care. What steps has the ministry taken to ensure providers feel confident supporting practices like self-injection or self-testing without, feeling their professional authority is being challenged or undermined? Karen, please.
Hello. Ask the question again because I'm on a move.
Okay. So, like when you shared, you discussed about things, but as trust is an essential, base for self-care. So, when you were taking it ahead, what steps did ministry take to ensure that the providers, the healthcare providers, feel confident supporting practices like self-injections or self-test without without feeling challenged or undermined, transferring power? Yes.
What we have done in Kenya, we have made sure that we have trained the healthcare providers with knowledge and skills on how to be able to transfer the same to the client. So what happens is when a clients come to the facility, they are, first of all, I'll give an example of DMPA SC. They are taken through how the injection works, for how long it works, and how they can be able to use it as a self-injection. And then they are taught on the steps on how to inject themselves. On the first time, the healthcare providers will teach them, the healthcare provider will do it. The next visit, the client will be able to come to the facility and inject themselves in the presence of the healthcare providers. And then from there, they will be followed up in the household by the CHP who takes care of the community. So that skill is transferred. In case they are also encouraged, they can always come back to the facility if they cannot be able to do it by themselves at home. But the trust will always be there between the provider and the healthcare and the client, because once they have been taught, they are also referred to the community where we have the CHP who will continue following up with the same. So the trust will always be built, and then they are encouraged always to come back to the facility in case they need more information or in case they develop maybe something from the provider perspective, and they can always ask a question through phones because the CHPs have been given phones by the government. So in that, the trust is built between the client and the healthcare provider and the CHP at the community level. Thank you.
No, no, thank you so much. I think trust building and putting trust in something at a healthcare provider level or in PHC level is very important, and we should take care of these aspects. So thank you so much for that response. And Dr. Roslyn, we have a question from our audience, and they're very keen to know that how effective was the media in Uganda when you were working towards enhancing the self-care agenda? Do you have any perspectives on that? Actually, Dr. Roslyn is in a difficult internet zone. Maybe we can come
I'm
back
trying
to.
I'm trying to respond. Thank you so much. One thing I want to say that as a country, we have partners who are supporting us in implementing software. And SEHAD is one of the partners that is leading on advocacy. And they've worked with most of the media houses. They have built their skills. And this media fraternity, they've gone as far as publishing papers on software. So working with the media has been very easy, even as Minister of Health, through the Public Relations Officer of Minister of Health, we've mobilized quite a number of journalists in the country and rated them on software. So it has been smooth, actually. With the media, the most important thing is giving them the information that they can use to be able to continue advancing and give positive reporting. So thank you for that question. But we are really working very well with the media. Over.
Thank you so much. Thank you so much, all the panelists. And we see lot of questions coming in and in the chat also. So please keep on having a look at the questions. And whenever you feel that you need to respond in chat or you need to respond directly, then you can please shoot it. So my next question is again for Dr. Alex. So can you please tell us that PSI's approach often starts with mapping the full user journey, where the journey, where in that journey do you see the biggest system or the frictions that self-care can realistically solve, and what does it take to remove them?
Great question. Yeah, I think, first of all, I think we need to be clear that that varies very greatly from context to context, right? The findings from journey mapping, what actually the biggest bottlenecks are for the consumer to access the care they need. It can be distance, it can be cost, it can be stigma, it can be the clinic hours and I think self-care can help with each of those. But I think there's one also that I believe it was Maureen who touched upon it, which is the lack of all the information that's needed to take informed decisions. And very often what that results in when you look at the journey that clients have to go through is some sort of trial and error, right? They will go to the drugstore. They will get something that doesn't help. They will go to a clinic. The provider may not be there, or the product they need or the service they need is not available. And so it ends up, each time it adds up also to the cost in terms of travel, in terms of all the different costs involved in getting the product or service. So I think self-care has, and especially if accompanied by the right information, supported by digital tools to the extent possible, and with the necessary linkages, I think can really make a huge difference here. So not only to make that journey smoother and result in better outcomes, but also less costly to the client and therefore less likely to induce financial hardship.
Thank you so much.
Thank you,
Thank you
Angus.
so much. We like as I say that this year theme for UHC is also, like we need everything affordable. We need everything available. We need to strengthen our PHC because we are sick of it. So definitely, thank you so much, Dr. Alex. And with this, I also see a question in the chat which talks that would age under 18 matter in self-care? Example, family planning, contraceptive, and all. So I know I can throw this question at our panelists, but I want to intervene here that we need to advocate for reducing age of consent. We have young people struggling to access or get their rights. So for my personal take on this would be, why are we waiting till 18 to give health, give rights in hands of people? So more to talk about it, maybe in our future webinar, we talk about age of consent and rights of young people, especially young and marginalized people. Yes. So with this, Karen, we have a lot of questions for you. And next one is for you specially. And when you were talking about your presentation, and as Kenya strengthens community and digital health systems, how are provider workflows and training being adapted to integrate self-care tools? How are you doing the referral, self-monitoring while still maintaining your clinical oversight? Karen, can you share some expertise on this?
I'm not very sure if you can hear me because I'm on transit.
We hear you very clearly. Yeah.
All right. What we have done, we have developed tools. Right now,
Oh, we are unable to hear Karen. Karen, can you hear us? So
we are
sorry,
using
you're
We are using the registers, whereby when a client is offered a self-care service, it is recorded in the primary tool, where it is transferred now to the national digital platform at the end of the month, where we have a summary tool. But right now we are digitalizing so that the services are not recorded in registers. They are now recorded on e-tool that is being used now. It's being introduced across the country. So all the indicators that we can be able to track in terms of self-care will be now be uploaded on a Kenya Health Information System, so that you can be able to use it if you want to use it, the information or data, for research purposes.
No, thank you so much. I think it is a very integral step when we are talking about digitally bringing systems or digitally bringing data onto our side or putting it all together at one place at the government central level. So thank you so much, Karen, for that. And with this, onto a similar question for Dr. Roslyn. Like Uganda's new self-care app is supporting family planning, ANC, HIV, STI, NCDs. How is the ministry ensuring that this tool is integrated into provider workflows and your HMIS systems, so that no parallel system of digital, data or something is created? Dr. Roslyn, can we have you on this?
Yes, this is the last I can answer and run to the panel. Thank you so much for bringing this up. The very reason why the self-care applications app has been developed is to ensure one platform, integrate into one, which will then be easy that when an individual is navigating, will find everything that one-stop shop, as compared to having so many applications in the country. And actually, the permanent secretary made it clear that there should be reduction in so many applications and let's have one. So this application is still work in progress. We have discussed with the DHI, the data department, on how best we can have it linked to the HMIS data system so that we can quickly get information that we want out of this application in terms of usage and any concerns that come out from the community. So our application is meant to ensure we have one platform and increase access to information and services for the people. Thank you so much.
Yes, no, thank you so much, Roslyn. I think this was a very, very, important aspect because we are doing a lot at country level, but till the time we need to integrate everything. And with your experience, I think, and with Kenya's experience, we are learning that as countries, how do we build these interventions integrated for larger level scale up and implementation at large scale. So thank you so much for that. And with this, Dr. Alice, I have the last question for you, I promise. And this one is that when you think about health system performance, efficiency, access, and quality, what types of metrics or early signals help you judge whether self-care is actually shifting outcomes for providers and facilities from your experience?
Another great question. Well, I think there are several, right? The measuring the quality is definitely critical. Efficiency, we already discussed earlier. Do this shift to self-care? Does it indeed translate into greater efficiency in terms of the use of the time of the providers? In terms of access, I mean, does it really simplify the journey of the consumer? Does it make their access to what they actually need and the resolving of the health issue easier and less costly? So I think those are measuring the quality, I think, of self-care is something that the SCTG is already looking into and has done some research into. So I think there's definitely progress in each of these three metrics. So yeah, I hope we can start seeing those metrics being reported and built into systems, so that that will give additional evidence to countries that are at earlier stages to take on the effort to develop self-care policies and to build it into their health systems.
No, no, thank you so much. Thank you so much, Dr. Alex. And I personally feel that every number that we are reporting is an individual. So every person who is getting into the system, who is actually accessing a service, he's actually thinking, planning, taking care of his, her, or their health. So thank you so much for that. And with this, I would also request all our audience, if you have any perspective to be shared, this will be the time. Please raise your hand and we can open your mic. You can share your perspective and we'll be happy to listen in. If anybody from the audience, okay, otherwise, maybe, we can just think that this was a very integral discussion, especially today when we are just going up to the UHC Day, Universal Health Coverage, day that we will be observing on December 12th. So, and we need access, we need universal access to sexual reproductive health rights justice, and self-care pushes for it. Self-care is one of the stepping stone for it. And with this, I'm very, very happy that we had this discussion. And I request you all to please follow our social media channels. We have a lot of discussion going on as we are going ahead for 12 days of UHC. And as we are prepping for next year, we have a lot coming in. So stay tuned. And with this, I wish you all a very happy end of the year. And thank you so much for joining us today. Thank you. Bye-bye. Thank you to my speakers, panelists, SCTG team. Thank you to everyone. Yes.